Good evening, everybody. I'm Michael Sector. I'm the CME Director for Obstetrics and Gynecology at the University of Calgary. Today we're presenting a webinar across the country through the Society of Obstetrics and Gynecology Canada on multidisciplinary management of respiratory failure and critical care of the pregnant patient. We gave this talk locally last week and we had an exceptional reception. So we thought we would distribute it to a wider audience and modify it a little bit. I'm about to get started and introduce our speakers today. I did want to cover one housekeeping item, which would be questions. We have a question and answer feature down in the center of your screen at the bottom. Some of our participants and some of our panelists are going to try and answer questions for you as we go, but we would also encourage you to vote up questions so that we can answer them as a group. And I'll be moderating it at the end of the talk, and we will ensure that your questions are answered. We're looking at roughly a 45-minute talk with at least that amount of time for questions and answers after that. And we welcome you all here tonight. So next slide, please. So this presentation is copyright compliant, and we have no disclosures that are relevant to the presentation. And next slide, please. We acknowledge the traditional territories of the Blackfoot and the Treaty 7 peoples. Next slide, please. So just let me know if you're not getting my audio. I'm introducing Dr. Stephanie Cooper, who is maternal fetal medicine specialist here at the University of Calgary. Dr. Nick Papalia, who's a PGY5 with an interest in critical care and obstetrics. We have Dr. Megan Vlashard, who is obstetrical internal medicine. Dr. Selena Au and Dr. Josh Ng are critical care specialists. Dr. Rob Thompson is our obstetrical anesthetist. Dr. Leslie Skeeth, who is with Department of Hematology, and myself and Dr. Thurston, who works with the Physician Learning Program. Erin Peterson is our project manager, and I'm going to invite all of these speakers to talk about their financial affiliations.
So I'm Megan Vlashart. I have a education grant from the Taylor Institute at the University of Calgary, and then investments in Johnson & Johnson.
I'm Leslie Skeeth, and I have a grant unrelated from CSL Behring and honoraria from Leo Pharma.
And I'm Josh Ng. I'm a critical care fellow here. I'm a co-investigator on a grant that's led by Dr. Gina Parsons-Lay, entitled Socio-Cultural Implications of COVID-19, Educating, Engaging, and Empowering the Public.
Excellent. Next. So we have received support from the Physician Learning Program, but we have no other conflicts to disclose. And with that, I'll invite Dr. Papalia to begin our case.
Thank you, Dr. Sector. So I'm just going to start by doing an overview of our learning objectives. So our objectives for this webinar are to investigate a pregnant patient with respiratory complaints during the COVID-19 pandemic. We want to be able to appreciate the relevant physiologic changes of pregnancy and how they may impact diagnostic testing and treatment. You'll be able to develop an approach for airway management of the critically ill pregnant woman. You'll be able to navigate the clinical care for a pregnant patient with an influenza-like illness during the COVID-19 pandemic. You'll be able to recognize and optimize roles of multidisciplinary teams. And you'll be able to describe the clinical aspects of a critically ill COVID-19 pregnant patient. Next slide, please. So for our agenda today, we're going to spend the first few minutes talking about the available data regarding COVID-19 and pregnancy. Then we'll move into a multidisciplinary case management scenario. And then we're going to finish with a Q&A discussion period at the end. So I'll let Dr. Stephanie Cooper take over for some available data review.
Hi, everybody. I'm so happy to be part of this, and it's been so rewarding and interesting to work with a group of people who are all interested and working with COVID in different fields. So I think what's very frightening and interesting and challenging is the fact that we're not able to use the same level of evidence and data that we have for other areas that we or other conditions that we treat, and to a point where the best level of evidence is case reports and case series, and there's no RCTs, especially related to pregnancy-related monitoring, care, management. So lots of expert opinion. But the other thing that's very interesting is that we're actually learning about things not by published literature, but by the Twitter and Reddit and the media. So this is, for example, is an article that came out in the New York Times that was talking about 3 pregnant women with COVID in the Bronx. And again, this was not published. And at the time, there was very few reports of people who were actually critically ill and pregnant at the same time. Next slide, please. So what I want to talk about a little bit about, and what we're, the context of tonight's talk is, maternal morbidity and mortality with COVID. So I think what we're seeing with more and more reports is that there's a similar distribution of mild, severe, and critical diseases compared to the general population. But I really want to emphasize general population in that includes older people and people with comorbidities, and generally pregnant women are young and healthy. So I don't know if we can necessarily compare overall to the general population, and I am looking forward to more studies that have age matched controls with pregnant and non-pregnant women. Again, really it's just case series, case reports, and registries that are driving our information. Overall, there have been 2 maternal deaths in Iran that have been published, but a number of maternal deaths that have appeared in news media. Next slide. In the beginning, I think what really was guiding a lot of people's understanding was Wuhan, and very much this idea was passed on that pregnant women are not more likely to get severe disease, which is true, and that a majority of people have mild conditions, which is true. But I think what we still have to recognize, even from the Chinese data, is that if we have 8% of women who have severe disease, or 3% that end up in ICU, if we have 100 patients, that's still pretty significant, because the management of a pregnant woman is very complicated because of her pregnancy and because of the fetal impact. Next slide. So I think, and again, there was always some caution in being able to extrapolate a Chinese population who may have less obesity, type 2 diabetes, to a North American population. So I think everybody was very interested when New York started publishing. And I'm sure everybody knows this series from March, where they described 43 patients. And again, 86% mild, 9.3% severe, and that 4.7% critical. But again, think 4.7% of a pregnant population having critical disease is still pretty frightening. Now, I recognize, I think what people are relieved about is that pregnant women are not more likely than the general population to have severe disease, as we saw with H1N1 or with SARS or with the Spanish flu of 1918. So, but still, I think why I want to emphasize this is that we really do need to consider the pregnant woman with critical disease in advance of actually meeting these patients. And I know some centers in Canada already have, and that's what the whole point for bringing all of us here together tonight is. Next slide. So back to the Breslin article, I think a couple of interesting things that came out of their series was that not everybody was symptomatic at presentation. So there were 2 people who were asymptomatic on admission, and they actually, because they had some people who developed illness while they were admitted, and they had screened negative when they were first admitted, they began a policy of universal screening and universal swabbing for all their patients. So 2 actually were asymptomatic, but then went on to develop severe disease. The other thing I think was interesting is that one person just had mild symptoms when she was admitted to hospital, but then ended up having severe disease. Next slide. From that, again, a letter to the editor, which is now the highest level of medical evidence, it seems, from New York, and describing the asymptomatic potential COVID positive patients. And I know there's lots of debate saying maybe they were dead viruses that were being picked up by PCR, but I think the interesting thing was that 10% of those who were asymptomatic but who tested positive actually developed symptoms while they were in labor or were admitted. Next slide. When we're thinking of some of the morbidity, and I'm glad that we have Dr. Skeeth, who's going to talk a little bit more about the coagulation part, but pregnant women do have different challenges in the sense, if you think postpartum with the cardiovascular changes are enhanced as well as during pregnancy. But I think, and we're still waiting to hear more as we get more evidence, but two patients described from this study where they ended up having cardiomyopathy and COVID, and the first patient was very ill and had a cardiac arrest, but actually was able to be revived. Next slide. I mentioned Mount Sinai here in Canada is the only Canadian cases that have been reported with significant maternal morbidity, and through with Dr. Whittle and her hematology colleagues. Next slide. I think, I saw this published yesterday, and it really is a call to bring all of these series and reports and together so that we actually can do some universal and global research into pregnancy and COVID. And I liked this quote, which says, "Pregnant women are currently not recognized as a population at risk. However, they might still be vulnerable for not only medical, but also social risks." Next slide. By the way, this is a very strange format. Normally when I do presentations and rounds, I always have lots of people I can look at and I can judge if they're looking at their feet or on their cell phones, but I feel like just talking to my computer is very odd. So I just want to review a couple of these case series. Italy, 42 pregnancy cases reported, with 7 ending up in ICU. In France, this is an ICU database. They mentioned 13 admissions for pregnant women. Next slide. The Dutch registry, and I found this one interesting when I first read it, because it was one of the first out there of reviews. And of 107 patients, 5 were admitted to ICU, and it just made me think, this is generally, we can't compare to. We have heard, numerous times, well, we can't compare to China, it's a different population. And we can't compare to the United States because it's a different population because of, obesity or type 2 diabetes, for example. But I mean, this would generally be considered in a socialized medicine country, healthy people, and they still had 5 admitted to ICU. Next slide. In the UK, similarly, reported 16 currently pregnant, 3 with advanced respiratory support needs, and 21 postpartum, 6 with advanced respiratory support needs. Next slide. As I mentioned before, only 2 maternal deaths reported, both from Iran. They were both said to be healthy, and 3rd trimester, which is where I really am most concerned if we're thinking about maternal morbidity and maybe mortality, but also because now we have a fetus at a viable gestational age. This woman was admitted to ICU and had needs for intubation. But I want to bring one point up about this case, was that she ended up going into spontaneous preterm labor, and it was undetected. And the only reason they knew was that there was spontaneous movement under the sheets, and then the baby delivered. So just emphasizing the importance of fetal and uterine monitoring for critically ill women. Next slide. And then the second case report was a 22-year-old at 32 weeks, again, healthy. Interesting that she didn't have a temperature on presentation, so that message that someone must have a fever, I've heard that, and we have to remember there's lots of atypical presentations. she initially improved after her delivery, which they decided to do because she was critically ill, but then deteriorated and died 7 days later. What was, again, an interesting point in this case was that they made their uterine incision, and then they did an amniocentesis essentially through through an intact sac, and that culture came back positive. Now, the baby was initially separated from mom and was initially negative, but the follow-up swab was positive. Next slide. So that is pretty much a review of a lot of the literature that's out there. I know there is some more, but really, again, where we're finding cases is in the media. And we have a case on the left is a respiratory therapist who had COVID, and she actually was induced and had a vaginal delivery while she was in a medically induced coma, which I thought was very gutsy of them. And, you know, everybody has probably heard about the case of the UK nurse in the top left-hand corner. There's been other reports in other countries, but this is just a smattering. But again, I think we have to really not underestimate that the significance of this disease in pregnancy. Next slide. I'm going to pass this over now so we can go through our case. And the idea is that we consider multidisciplinary approaches and you know, concerns as we think of a pregnant woman who is developing significant disease and what that means for her medical care, her obstetrical care, and of course considerations around delivery of a potentially premature baby. And I think then I hand it over to Nick.
Perfect. Next slide. Thank you, Dr. Cooper. So here I'd like to introduce you to a theoretical case. Our patient is a 34-year-old gravida 1 at 30 and 2 weeks gestational age. She's presenting to a level 2 center in the emergency department with cough and shortness of breath on exertion. She's had a sore throat and stable, mild, dull headache for 7 days. She's had no improvement with acetaminophen. Her cough has been present for 5 days with subjective fevers, anorexia, and fatigue. Her shortness of breath started about 24 hours prior to presentation and is significant after a single flight of stairs. Her partner suggested she try his Ventolin, but she did not experience any relief. Throughout this, she's had normal fetal movement, but she does note some mild irregular menstrual-like cramps. Next slide, please. This pregnancy is significant for elevated blood pressures in the first trimester, for which she's been given a diagnosis of essential hypertension and been managed with a small dose of labetalol. She has class 2 obesity and is on aspirin for preeclampsia prevention. She has no allergies and is otherwise healthy. Next slide, please. Her triage vitals can be seen here, and I will note that she requires 2 liters of oxygen via nasal prongs to achieve an oxygen saturation of 96%. Her physical exam is relatively unremarkable except for a dry cough. To determine the abnormal vital signs in the context of pregnancy, it's essential to define what the normal vital signs in pregnancy are. So we're going to go through a paper on the next slide. So just published in March, this prospective study of more than 1,000 healthy singletons in the UK demonstrates gestation-specific vital signs quantified by percentile. On the first graph on the left, you'll see a slight rise in blood pressure approaching term. Now, what's important here to note is that in the context of COVID, it's the systolic pressure that we want to be attentive to. A systolic pressure of less than 90 is lower than the third percentile, and significantly so at 40 weeks. From the graph in the middle, you can see the 10 to 12 beat per minute rise in maternal heart rate towards term. Here, the upper limit is worth noting, and about 3% of women near term will have a resting heart rate of 115 beats per minute. On the top right, it's clear that the respiratory rate does not change with pregnancy. And in a few moments, Dr. Rob Thompson will review which respiratory parameters do change in pregnancy. Finally, oxygen saturation is fairly consistent during pregnancy, so anything lower than 94% is abnormal. Now I'll turn it over to Dr. Thompson to review the respiratory and arterial blood gas changes in pregnancy.
Next slide, yeah. So I think it's important to remember that a lot of these respiratory changes happen quite early, as soon as the first trimester. And these are important because patients' functional reserve capacity drops quite a bit. So positioning in these patients can significantly decrease their oxygenation. as much as a 10 millimeter mercury of difference drop going from upright to supine can happen at term. And this is obviously an issue in women that are sick. The other thing to note is the increase in minute ventilation is primarily driven by their tidal volume and not their respiratory rate. So it's important to remember that a high respiratory rate is not a normal feature in a pregnant patient when they are presenting to hospital. And then with these changes, their reserve is obviously much lower. So decisions on what to do with these patients need to be made quickly if they're deteriorating, because these will obviously be exacerbated with their higher metabolic rate and their lower functional reserve volumes. Next slide, please. So when we look at blood gases in pregnancy, if you can look on the bottom right-hand corner, the non-pregnant state versus the pregnant state, again, the respiratory changes happen quite early in pregnancy, as early as the first trimester. And these are all adaptive changes to help oxygenate the fetus. There's a respiratory alkalosis, and this helps stimulate 2,3-DPG to help transition oxygen to the fetus, as well as all the difference between the PaO2 and the PaCO2 between the mom and the baby, help move oxygen down a gradient for the baby. Now, the increased minute ventilation offsets the increased production of oxygen, or increased consumption of oxygen and production of carbon dioxide more than enough, and that's why they develop this alkalosis. So when interpreting blood gases, it's important to know where they are, and that these differences do exist, but a lower PaO2 is not normal in pregnancy, and that has to be sought when we're looking. The lower bicarb is adaptive, and that is normal. Next slide.
Perfect. Thanks, Dr. Thompson. So back to our case in the emergency department, labs are requested, and you can see the ones that were ordered here on the screen. From that, what we're going to note is that the platelets are slightly depressed. The lymphocytes are low. There's a slight rise in the ALT. And the serum creatinine is relatively normal, but I will remind people that the creatinine does drop in pregnancy. So would not automatically expect a result to be showing up as abnormal, but be significantly elevated. There's trace proteinuria on protein dip, and on the spot protein to creatinine ratio, it is normal. A chest x-ray is done and demonstrates bilateral lower lung zone predominant airspace opacities. And an EKG is also done and demonstrates sinus tachycardia. Next slide, please. So here we'll review the ABG. So on room air, you can see that the pH is slightly alkalotic, slightly outside of the range, which would be consistent with an increased respiratory rate. Oxygen is slightly abnormal, and as you can see from the bicarb, that is not yet compensated. Next slide, please. So useful and safe approach we are advocating for when it comes to a pregnant patient with respiratory presentation can be seen here. So first step would be to ensure that the oxygen saturation is at least 95%. And if it's below, then you would supplement with nasal prong, face mask, or a non-rebreather as needed. Chest imaging in the form of an x-ray and lab should be completed, and necessary help and guidance should be sought earlier rather than later. So these patients can get quite sick, and it's not uncommon to need medicine, anesthesia, and critical care colleagues involved. Now, our zone within Alberta Health Services has created an algorithm that considers the local infrastructure here and will not be universally applicable, but having a multidisciplinary approach is essential and will be unique to each health system. And we'll walk you through what we would do here for a pregnant patient. Next slide, please. So due to the cramping, OB at the level 2 center assesses the patient and recommends transfer to the level 3 center based on the gestational age, which here is less than 32 weeks, even though she's not in labor. Due to the hypoxia, internal medicine sees the patient in the emergency department prior to transfer to assess the suitability for ward admission. And the accepting physician is contacted by the obstetrics team. And on the right side, you can see the fetal heart rate tracing, as well as the relative absence of any uterine activity here. Next slide, please. So the first step in a patient presenting either to the emergency department or to triage on the OB unit is to determine whether or not the primary concern is an influenza-like illness symptom or obstetrical. In this case, it's influenza-like symptoms, and that will bring us to the next slide, where we can review our second point, which does this patient need supplemental oxygen or admission? And so on this, what you can see is that if the patient requires any supplemental oxygen to maintain an oxygen saturation of 95% or more, that would warrant an admission. And our next step is determine whether or not there's rapid deterioration. Dr. Vlasher will review early warning signs for pregnant women shortly, but in this case, right now, there is no evidence of rapid deterioration. But this patient does have an obstetrical concern. It's not the primary concern, so at this point, we're going to have both teams involved. Next slide, please. So this patient's been admitted to our level 3 center under internal medicine. She's been administered 2 liters of oxygen by nasal prongs and successfully above 95%. She has been initiated on prophylactic low molecular weight heparin, and it has been weight-based dosed. She's initiated on community-acquired pneumonia antibiotics. She has vital signs Q4 hours, and she's been given Tylenol PRN for fever and headache. And she has an NST done twice daily while she's on the medicine unit. I'm going to hand it over to Dr. Blashert to talk about early warning systems in pregnancy.
Okay, thanks, Nick. In terms of admission of these patients, as Dr. Cooper was saying, because we know so little about what this disease does to pregnant women and, to be honest, in young people in general, the use of early warning systems can be quite helpful in this situation and many situations. So we developed a list of symptoms to watch out for our colleagues who potentially have less experience within internal medicine with management of pregnant women, but as well with our obstetric colleagues who potentially have less experience with management of respiratory diseases in pregnancy, and used both the Q-SOFA as well as the maternal early warning signs as to guide us. Our oxygen target was a decision with ICU locally. And what these are essentially is suggested ways in which nursing can notify the attending physician of change in clinical status that would prompt assessment. Next slide, please. So the maternal early warning or any early warning score is a goal to detect clinical deterioration and facilitate earlier intervention. And what we do, and you want to use routinely collected vital signs. There's a predetermined calling criteria, and that legitimizes calling, and an abnormal early warning system does predict death and cardiac arrest in non-pregnant women. The maternal early warning systems are developed to account for the physiologic changes of pregnancy. In terms of the Muse specifically, it's 85% specific and 86% sensitive for predicting maternal morbidity. And simple scores are favored more than over complex algorithms or other complex scores just because of ease of use. In terms of a prospective analysis, there was in the UK, there was an 18% reduction in severe maternal morbidity over 180,000 deliveries when a maternal early warning system was activated. Next slide, please. So this is the maternal early warning score in its completeness, and you'll notice that there's both yellow alerts and red alerts. A red alert requires 1 and a yellow alert requires 2 in order to activate, and we took our criteria from both the red and yellow sections. Next slide, please. Q-SOFA is an easy 3-point scale that's already used in terms of the definition of sepsis and is familiar to many internists and non-OB practitioners. Q-SOFA has not specifically been validated in pregnancy, but its sensitivity and specificity for the identification of non-specific sepsis, so not specific to COVID-19, has been studied. And it does have a higher specificity than the SIRS criteria, but a lower sensitivity at 35%. But however, when we're talking about wanting to rule in these people, potentially a specificity is better. Next slide, please. So in terms of this case, using the early warning system, and The nurse assessment in the morning shows that the patient's temperature remains febrile at 38.3. Her heart rate has increased to 122. Her respiratory rate is 24. Her blood pressure has decreased to 90 on 62, and her oxygen saturation is now 91% on 2 liters. And we've talked previously that we want to maintain this greater than 90 or 95% or greater, and therefore the oxygen is turned up to 95%. So using our items for rapid deterioration, you can see on the right of your screen that she has now met multiple criteria, and so the physician is called to assess. Next slide, please. So the pod physician was notified, and on examination, she has noted to have increased work of breathing. Labs were repeated. A portable chest x-ray shows increased bilateral airspace disease, and ICU was consulted due to her change in clinical status. Next slide.
Okay, so team meeting is held with the on-call anesthetist, OB, internal medicine, intensivist, and the neonatologist. The patient's respiratory status is deteriorating, and it's anticipated that sufficient oxygenation by face mask or non-rebreather mask will not be achieved. So together, the team decides to admit the patient to ICU for mechanical ventilation, as the aerosolization risk of positive pressure ventilation to other patients and healthcare workers is too great. And Dr. Thompson will give a little bit more background about airway concerns and options for ventilating patients.
So I think first off, one of the things we've been avoiding is non-invasive positive pressure ventilation. And part of that is the risk of aspiration in these patients, but also the fact that they'll deteriorate quite quickly. So it hasn't been in our site something that we've been using, and we've been going straight to invasive ventilation when they need it. Now, it's important to recognize that these airways are different, and not only are there anatomic and physiologic changes, but there's also human factors changes because of the move to, over many years, most women having neuraxial techniques for their C-sections and procedures that most physicians don't have much experience with the pregnant airway. There's also more stress. There's 2 patients. There's many things going on, and these can all cloud people's judgment. But it's important to remember that there are significant anatomical changes. So it's important to do a good airway assessment. Regular features that make an airway difficult are going to make an airway even more difficult in a pregnant patient. And an example in ours would be the obesity. Patients do gain weight, on average 30 to 35 pounds, which can significantly change breast size and neck circumference during the pregnancy and make the view quite a bit more difficult. As well, they are at risk for pulmonary aspiration, and this increases during the pregnancy. So if possible, it is good to increase the pH and to increase gastric emptying by giving medications in time before intubation is attempted. Positioning is extremely important. I talked earlier about changes physiologically with reserve volumes, and once patients are put in a supine position, the ability to oxygenate them becomes less. So it's important to position patients in a more seated, at least 30 degrees head up, and pre-oxygenate them quite well, because they will desaturate quite quickly, and that's despite being pre-oxygenated. So again, one of the reasons why the non-invasive ventilation is not a great choice, because once they start deteriorating, they will go down that pathway quite quickly, and once they're mid-apneic, they'll desaturate quite quickly. We've kind of been going away from cricoid pressure just because most of the research that's come out over the last several years has shown that it just delays intubation in a rapid sequence fashion, and just takes longer for people to be intubated. It's still considered a gold standard, but it is quickly falling out of favor. In particular to COVID patients, we've been using video laryngoscopy. For that reason, people are able to have their face further back from the patient when they're intubating to decrease exposure to these patients while they're intubating. Obviously, we're doing a rapid sequence induction because of the risk of aspiration and the speed with which they're going to desaturate when they're made apneic. So an awake fiber optic intubation may still be something that needs to be done, but it has to be thought of in the caveat that that's going to be a higher risk for everybody involved. So there has to be a little thought done ahead of time so that we don't end up going down a pathway when there really isn't a lot of time to go down plan B or C with these patients. And I'll pass it on to Nick Papalia.
Thank you. So our patient is safely but urgently transported to the ICU for controlled intubation and mechanical ventilation. She's sedated with midazolam and fentanyl, which are safe in pregnancy, but can be associated with fetal heart rate changes as well as hypotension. Our patient is meeting oxygenation and CO2 parameters on moderate ventilation settings that you see in the middle of the screen. Continuous electronic fetal monitoring is applied to assess the fetal tolerance of the maternal condition and is normal. Next slide, please. Over the course of the day, our patient's respiratory status deteriorates further, requiring increasing FiO2 and airway pressures. She's therapeutically paralyzed as per the local ARDS protocol, and now her mean arterial pressure is declining to below 65. So recognizing the direction that this patient is going, your mind fills with questions. So is it safe to use vasopressors in pregnancy? Is ECMO indicated, or when is it indicated? And do we need to deliver this patient based on her overall status? Next slide, please. I wanted to cover shock in pregnancy. So shock and blood pressure are really related to the cardiac output and the systemic vascular resistance. So in pregnancy, cardiac output does increase, but the systemic vascular resistance decreases more so. So overall, we have a relative decrease in blood pressure. The aortocable compression from the uterus on the major vessels can impair venous return and inhibit cardiac output. And this in turn can impair placental perfusion and fetal oxygenation. So placental perfusion is really a function of cardiac output and mean arterial pressure. Fetal oxygenation also requires a PaO2 gradient. So maternal PaO2 must be higher than fetal for the fetus to be able to extract oxygen. And without adequate oxygen, fetal blood becomes acidemic, and this stimulates chemoreceptors, causing fetal heart rate changes, typically in the form of tachycardia and reduced variability, which can be followed by preterminal decelerations and subsequently fetal demise if it's not alleviated. As far as shock is concerned in pregnancy, in this situation where it's related to infectious cause, it would be classified as distributive or septic shock. The other one that would be more common in pregnancy would be hypovolemic, so low fluid or blood loss. The other ones are cardiogenic and obstructive, but those are less common in pregnancy. So for distributive shock, the way that I like to think about it is overall your tank is expanding and the relative fullness of the tank is reduced. So this can be diagnosed with straight leg raise or a small fluid challenge, but also recognizing that COVID positive patients can easily become fluid overloaded. And we can talk about that a little bit later. But in order to correct mean arterial pressure of less than 65, what our first line agent would either be norepinephrine or phenylephrine to correct the increased capacitance or the decreased resistance of the vessels to maintain perfusion. So there's limited data on vasopressors, but these two would have the most, and there's no associated fetal harm. Next slide, please. So the prone position is something that many will have heard about and some have firsthand experience with. So if not ARDS in and of itself, severe illness in COVID mirrors ARDS and the impairment of gas exchange. The prone position helps to maintain adequate oxygenation by matching ventilation and perfusion to facilitate maximal oxygen into the blood. And this is recommended by most, if not all, of critical care societies for at least non-pregnant ARDS patients. And the impact is significant enough that survival benefit is seen. So what about pregnancy? Well, there's been some documented success in oxygenation by proning pregnant patients, even in the early third trimester. It's not in our local protocols because pregnancy is considered a relative contraindication to proning. And as you can imagine, there are several unique challenges and limitations to proning in pregnancy. So in the same way that proning in the supine, that laying in the supine position, proning can result in aortocable compression. The abdominal pressure can result in decreased venous return, which is counterproductive. And as Dr. Thompson reviewed, the maternal airway and physiologic changes provide less margin for error if a problem does arise during ventilation. Fetal and uterine monitoring can also be quite difficult, and should an emergency delivery need to occur, there would be a few additional steps. Another way to improve ventilation and perfusion matching with fewer limitations would be positioning the patient in the semi-recumbent position. And just want to stress the importance of uterine displacement, whether the patient's semi-recumbent, supine, or any other position where the uterus could sit on top of the major vessels. Next slide, please. So here's a diagram of how proning a pregnant patient was accomplished in the reported case out of Cincinnati. So they used about 8 or 9 pillows to prone their patient and continuously monitor her and her fetus. But going back to our case, remember that the mean arterial pressure is less than 65 and that her oxygenation and ventilation goals are being met on moderate settings. So for her hypertension, the norepinephrine infusion is initiated with a target mean arterial pressure of 65, and the markers of perfusion that are monitored in her are mean arterial pressure, urine output, lactate, and fetal heart rate. In the semi-recumbent position over the course of the day, our intensivists and respiratory technologists have been successfully able to wean her FiO2 and airway pressures, while her primary RN reports stability in her norepi requirements and achieving half a cc per kilo of urine output per hour. So there's been some discussion about the utility of ECMO in our hypoxic patients. So I'm going to ask Dr. Au to provide a little bit of context and some salient points.
Thanks, Nick. Can we get the next slide? So the decision for ECMO was something that we can, I guess, say we don't make lightly. It's something we would want to discuss with the multidisciplinary team as well as the multi-service team. The decision points, it really goes back to whether or not we can oxygenate the mother. So some of the changes physiologically we already discussed, but it also has ramifications as to whether or not we are able to use our usual tricks in the ICU. So for many of our patients who are in severe ARDS, beyond turning up the oxygen, if we can't oxygenate, we might consider using higher amounts of mean airway pressure, so higher PEEPs, for example. But in a 3rd trimester pregnant woman, she might have intra-abdominal pressures of 14. And so if we're trying to maintain some protective lung ventilation, so preventing barotrauma with plateau pressures less than 30, we might not be able to successfully do so. There are ways around this if, for example, we are able to use an esophageal balloon to measure some lung pressures, but that takes away one of our tricks. The other thing that we would have consideration of that Nick already discussed was whether or not we can successfully prone the patient. So if she's in 2nd trimester, we might be able to get away with it easily, but 3rd trimester pregnancy, we were only able to find some scant case reports of use within I guess ARDS and for the COVID or influenza-like presentations, there was only the 1 case report that Nick has mentioned. So locally, it's not a practice that we would be doing. And if I were to speak with my ECMO colleagues on this, they would actually vote or lean more towards if it was an earlier pregnancy where the woman is not ready to deliver yet, or there's too much risk for a baby, we would certainly consider offering the patient ECMO. Other considerations beyond oxygenation is the fact that we can't use permissive hypercapnia, for example. So sometimes we allow a patient's pH to drop quite a bit and the CO2 to go up in order to ventilate them successfully. But in the scenario where high carbon dioxide might not be very good for the fetal brain, it's something, again, we may have to consider and then make a decision to move towards ECMO if we're not able to ventilate her. And so when we look at what experience has been available so far, really we're looking at a lot of the experiences we gained through H1N1. So in this recent publication from the American Journal. They discussed a case series over 10 years of 54 women, where the majority of the reason why the woman has undergone ECMO is because of ARDS. They did report a very low survival rate of 33% of peripartum and 50% actual pregnant women. And so that's lower than other studies that have come out. And so I wasn't able to dive deeper into the study as it's still in press. But if we were to look at this larger systematic review that came out in 2016 from Moore, he looked at 45 pregnant patients, and of those, 33 were patients who were H1N1 ARDS patients, and the survival rate was actually pretty good. It's close to 80% and close to 70% for the fetus. And so again, this is a risk-benefit decision that we have to weigh in and discuss with our colleagues. Next slide.
Hi, it's Dr. Leslie Skeeth. I'd like to talk a little bit more about VTE and coagulopathy. So we do know that patients who are admitted with COVID are at risk of VTE. And when I say VTE, this is a combination of deep vein thrombosis and pulmonary embolism. And it's a spectrum where likely relating to acute illness, significant inflammation, and other VTE risk factors such as pregnancy. And so we're recommending in all admitted COVID patients to consider a standard prophylactic dose, low molecular weight heparin, weight-based, especially for those like our patient who is greater than 100 kilograms, unless there's contraindications such as bleeding, low platelets, or in labor. Next slide. The literature has been quite rapidly evolving with the risk of thrombosis and COVID. 2 weeks ago, we had case reports, and in the last couple of weeks, we've had 4 cohorts, mainly in the ICU, showing a high risk of thrombosis in non-pregnant patients despite prophylaxis. So we're still working through how this compares to non-COVID patients, and it does look to be, especially in the ICU, that this risk is high. We have one published cohort looking at the hospital ward, and this is similar to other acutely ill patients. There's been one case report of a pregnant patient with COVID and pulmonary embolism, and there's significant or ongoing research looking at randomized controlled trials, all of which exclude pregnant patients. But I think we can extrapolate what they find to look at the optimal low molecular heparin prevention dose. So a lot of happening in research. I think the bottom line as of today is really to think about DVT and PE and to investigate, even if a patient is pregnant with a CT scan, if there is worsening unexplained clinical status. Next slide. We're also seeing significant coagulopathy in COVID patients. This is generally mild, where there's mild thrombocytopenia, often platelet count greater than 100, mild elevations of INR and APTT, and often the fibrinogen is very high rather than low, just relating to inflammation. So these patients often do not bleed, they're more likely to have thrombosis. And we've had several publications that have now come out in non-pregnant COVID patients showing that there's a marked elevation in D-dimers that are predictive of ICU stay, mechanical ventilation, and all-cause mortality. So there's a lot of guidance documents recommending serial monitoring, especially if there are abnormalities or those who are acutely ill in all hospitalized COVID patients. Next slide. I'd just like to highlight the work out of Toronto, where they published on 2 pregnant patients who had progressive coagulopathy requiring delivery, and that this is significant overlap with what something that looks like HELP syndrome. Often liver enzymes are slightly elevated in patients with COVID, and they have the similar findings of the lower platelet count and sometimes abnormalities in the other coagulation markers. In both cases, they had markedly elevated D-dimers, about 15 to 17 fold higher than the upper limit of normal. So just also to highlight significant inflammation happening. One patient had a significant postpartum hemorrhage, and the other one did well with tranexamic acid and fibrinogen replacement, but all to highlight that this is an entity that we're starting to learn about and describe. Next slide. I just want to have one slide and comment on this condition that is evolving and we're learning more about, called the cytokine storm. This is really a significant inflammatory response that happens in COVID patients around day 7 to 10 and is associated with very high mortality. We're still learning a little bit more about it, but it's associated with high fevers, multi-organ dysfunction, and a lot of inflammation on the labs and increased markers of cytokine release. So far, we're learning that there are experimental treatments, clinical trials. High dose or prolonged steroids for this condition are still of unclear benefit and require consultation with a rheumatology or hematology team. And 2 investigational agents, tocilizumab and anakinra, have very limited safety data in pregnancy. So again, very careful discussions with a multidisciplinary team if there is evidence of the cytokine storm condition. All right, I'll pass it over to Dr. Cooper.
Okay, so you know, as obstetricians, I think our reflex is always to want to deliver when we have a woman with a significant medical condition, because then we no longer have to worry about her because we've given her to somebody else to worry about. But obviously, you know, the patient that we're discussing, you know, she is not improving and she potentially is getting worse. And now we're considering, you know, potentially ECMO, proning, and of course, you know, we're doing fetal monitoring, but we have to be aware that we could have an increased risk of preterm labor, as well as non-reassuring fetal status. Most importantly, if we are planning a delivery, we need as much time as possible because we have PPD considerations. As Dr. Thompson said, we want somebody who is well experienced with a pregnant airway. We want to have our neonatologists ready to meet a baby that may potentially have significant issues as well. So as much time and multidisciplinary discussion as possible when we're making a decision about delivery. Next slide. So COVID-19 and of itself is not an indication for delivery. So especially if you've got a patient who's, for example, 36 weeks with mild COVID, do not deliver her. There's no indication to do that. Now, if we have a patient who is critically ill, potentially delivery may improve maternal oxygenation success. You know, she has reduced oxygen consumption, and uterine involution may also improve breathing dynamics. Next slide. However, I mean, if you look at some of the case series that I was discussing earlier, there did seem to be a number of women who decompensated postpartum, and it's hard to know if that's just anecdotal or what the actual relationship with delivery and exacerbation could be. I mean, certainly we know that you know, a labor will increase cardiac output, but also with delivery and return of, you know, significant blood flow into the systemic circulation instead of in the uteroplacental circulation could potentially cause a negative effect clinically. In labor, the catecholaminic surge, which, you know, again, why I thought it was really gutsy for the case from Washington where they had a vaginal delivery, recognizing, of course, that that's not been published and it was just from a news release. Also with delivery, there's endothelial release of inflammatory markers, interstitial, intracellular, and intravascular fluid shifts. So in the setting of current severe disease, potentially all of this will be exacerbated with further endothelial and cardiac dysfunction, leading to pulmonary edema, third spacing, and potentially cardiomyopathy. So again, we're not really sure yet what the best thing to do is, but I think most of us would feel that if you have a critically ill woman into the third trimester, that we really should be considering delivery with multidisciplinary input. Next slide. so just again to be aware that regardless, moderate disease are at higher risk of C-section due to hypoxia and fetal heart rate abnormalities, but it doesn't in itself mean that vaginal delivery is a contraindication, especially for women with mild disease. But women who have moderate disease have an elevated risk for general anesthetic with maternal hypoxia, so early epidural if they are in labor. Next slide. And just quickly, because there's obviously been some discussion about, is there any harm with giving steroids for these women? As there's been some question about prolonged exposure to high dose steroids, but this is not for antenatal corticosteroids for fetal lung maturity. This is a short course, and especially if you're in the very premature gestational age range, benefit would definitely outweigh risk. And that is definitely a balancing act as we go forward. And next slide. Also, a quick comment on magnesium sulfate, same idea, benefit should be weighed against potential risks. Now, the further you get into a pregnancy and the lower baseline risk of cerebral palsy, we're likely less going to be keen to give magnesium sulfate if someone is critically ill at 32 weeks versus if she was 24 weeks. Of course, check renal function prior to initiation, and generally societies are recommending just to do the single bolus dose of magnesium sulfate instead of an infusion in the setting of respiratory distress. And next slide. I will hand this over now, but I just have one further point, of course, is to remember to include fetal monitoring and uterine monitoring as part of your surveillance for a critically ill pregnant woman in the ICU.
So on that note, we've been able to oxygenate and ventilate the patient well. However, on continuous fetal monitoring, an abnormal fetal heart rate was observed, and this did prompt delivery. She underwent a general anesthetic in the OR, and the neonate had APGAR scores of 5, 7, and 9, with the gas of 7.2, PCO2 of 63, PaO2 of 21, and a base deficit of 3. The neonate was admitted to the NICU for observation and is isolated awaiting testing. And the patient, we can go to the next slide, sorry. The patient is transferred back to the ICU for mechanical ventilation until she is able to be extubated. And once extubated, the plan will be to go return to a COVID internal medicine unit where she can be observed until she can be discharged once off of oxygen.
Hopefully Dr. Sector's audio will come on for the question and answer period. But if not, just again, if you can put your questions and answers in the Q&A area, and if you see a question that you like, to give it a thumbs up, because that actually will prioritize questions up on the list.
So
there he is.
Yeah, I'm good. The first question is actually for Dr. Vlachert, and that was, what are your thoughts about lactate as a surrogate for BP in QSOFA assessments? I'll let you handle that one.
Yeah, for sure. It's a great question. I think the challenge with the QSOFA is that it's a very non-specific measure, but it's really easy to remember and to use. And so that's the reason why we chose it. In terms of the lactate, in the general ICU population, it has been shown when you add lactate to the QSOFA and a lactate of greater than 3 generally, that it increases the sensitivity of the QSOFA for the identification of sepsis. However, in terms of as an early warning sign or in an early warning system, the lactate is hard to measure. You either have to do an ABG, a VBG, or a serum lactate, and a serum lactate, at least at our center, has at least a 30-minute turnaround. And so we didn't include lactate. However, if the lactate is abnormal, that would be something else to consider in terms of the illness and the critical illness of the woman. From a blood pressure perspective, using 100 is actually probably generous. The Society of Obstetrics and Gynecology from Australia and New Zealand actually, when they modify the QSOFA for pregnancy, they use a blood pressure threshold of 90. And that 90 to 100 range in terms of the maternal early warning system is that kind of yellow zone, and then less than 90 is that red zone. We wanted to make sure that the Muse and the Q-SOFA were similar, and so chose 100, but know that 90 is certainly more sensitive in terms of severe maternal morbidity.
Excellent, thank you. So the next question I think would probably be best addressed by Dr. Cooper, and that's for vaginal delivery. It has been suggested by some to proceed with vacuum or assisted delivery to shorten the second stage. Is this currently recommended?
Hi. That's a really good point, and it comes up. It's come up in a number of different discussion forums. I think again, if you have someone who has got mild symptoms, is there any real value to, I guess potentially to cause pelvic floor trauma or whatnot? Potentially as well. We're not 100% sure about vertical transmission, and will an operative delivery potentially increase that risk if it's not indicated. At the same time, if you have somebody who does have moderate symptoms, we know that pushing is, it's like I always tell my pregnant women, it's like a marathon. And certainly if you think about the cardiovascular changes alone, let alone respiratory as you're in the second stage, I think definitely someone who has, more than just sort of a stuffy nose and whatnot, that I think preventing a prolonged second stage does have definite does warrant some consideration. I think I would, if I at all was worrying that they were potentially getting worse and not stable in their symptoms.
Next question is for Dr. Leslie Skeeth. Do you think there is enough evidence to suggest an increased risk of arterial thromboembolism in COVID positive patients?
We are seeing in the literature in the ICU that there is a higher risk of myocardial infarction, stroke, microthrombosis, of CRRT lines. These are mainly in non-pregnant patients with other arterial risk factors. But I think to have a low threshold if things are changing, and to either investigate and consider empiric anticoagulation if things are really significantly worse in these patients. We're still learning a lot about this arterial thrombosis. There have been case reports of antiphospholipid antibodies being reported. This does not necessarily mean that they have antiphospholipid syndrome. These antibodies are present when there's inflammation, when there's virus present, and so far the case reports have been in IgA antibodies, which are not our typical APS antibodies causing disease. So I think just more research, but to have that thresholds to think about it. Thanks.
Excellent. So the next question is, I'm interested to know at what gestational age you feel that continuous electronic fetal monitoring becomes necessary in the intubated or ventilated COVID pregnant patients.
I can take that one, but I'm happy, again, if anybody's on the Q&A and they want to put their opinions in, or Colin Birch, who is our department head who helped organize this webinar tonight, or Nick as well. I'm not going to ask Leslie or Megan, sorry, no, but so I guess the question is, at what point in time would you seriously consider delivering for fetal indications? And also, of course, the more that you monitor, you will find, especially with earlier gestations, you're going to find atypical tracings, and what are you going to do with that? But I do think that if you have someone who is in the ICU or even in a medical unit with COVID, that you do have to have a plan for, very frequent fetal monitoring, if not, continuous fetal monitoring, and then figure out how to do that in a way that is, accessible and is being able to be interpreted real time, as well as does not put any healthcare providers at risk due to, PPD concerns. So, to me, I'm thinking, if I had a patient over 32 weeks, I think I definitely want to have very close fetal monitoring, because my reason or my threshold to deliver after 32 weeks is going to be very low. And between 28 to 32 weeks, it's a little, our outcomes are generally pretty good for the baby that is born in a tertiary center. with steroids, magnesium sulfate. When you're in under 28 weeks, it's really at that point, how is our monitoring going to be interpreted, and will potentially we deliver a baby early with adverse outcomes? So I think the idea is that, we don't want to do harm, and really do have to sort of make, careful considerations. And I think we'll learn more as we get more data.
Excellent, thank you.
I will just say, it's Colin Birch. I don't, there's any book on it right now, but I tend to agree. I think a patient who's deteriorating and is sick on the ward, the COVID ward, and who's in ICU needs continuous monitoring, I don't think, without doubt. I think the problem is you've got to bear in mind the gestation they're at. And I think if they're sick enough, even at between the 24 to 28 weeks, they need to be monitored at least twice daily. And then there's no book on this, but that just makes some common sense. But I think in an escalating situation where the patient is getting sicker, I think continuous monitoring, by virtue of the fact we are recognizing there's increasing complications with that patient, I think they need to be continuously monitored. And obviously with intermittent ultrasound based on the ultrasound on the fetal monitoring that you've got.
Excellent, thanks, Dr. Birch. Next question I think could probably be answered by Dr. Blashart, Dr. O, or even Dr. Cooper. Are there guidelines on which COVID positive pregnant patients should be transferred to tertiary care centers if you work in a rural center? So what would prompt transfer into, say, Foothills, for example?
That's a really good question. And I think there are not, as far as I'm aware, guidelines about recommendations specific to medical kind of symptoms of COVID in pregnant women and which of those should prompt transfer. I think it would depend on your where you are, what kind of relationship you have with your center. And I think it's actually a really good question for your local tertiary care center to answer, because it's really them that are going to be able to say, we either do or do not want this patient. And in my experience, much better, at least while we have created our patient flow algorithm, much better to try to answer these questions preemptively instead of at the time. In my personal opinion, which is essentially all our flow diagram was an amalgamation of our opinions, I would suggest that any pregnant woman that requires supplemental oxygen is at risk for decompensation. And the challenge, as Dr. Thompson has pointed out, is that pregnant women can deteriorate very quickly. And so waiting for her to start to change may make her transfer higher risk. And so I guess my recommendation is to chat with your local center, but to that any oxygen needs especially would be, at least make me nervous, and I would be certainly accepting any woman from the communities in Alberta for that indication.
I'm wondering if, Colin, maybe you can also comment on that from the obstetrical perspective.
Yeah, because we recognize, I mean, two things basically. It depends upon what your local facility is like, and there's different comfort levels with a different level 2 facilities. But I think I tend to concur. I think any patient that shows any instability to their O2 saturation needs to be moved out, because the propensity for those patients to, and we've seen this in what little bit of literature we've got, they tend to decompensate. When they do decompensate very quickly. So, I mean, I think it has to be taken into consideration where you are, how far you are away from tertiary center, how rapidly deteriorating. So you don't want to put, it's just like if there's a deterioration of a pregnant woman, you don't want to put her in the air if you happen to be 2 hours flights away. So I think it's a more complex question than just saying, well, it went on 2 liters of oxygen. I think any supplemental oxygenation, there should be due consideration to travel to a tertiary care center. But I think that also has to be tempered. Having worked in a secondary center many hours away from a tertiary center, you also have to take in consideration what that patient, how quickly you can get that patient from secondary to tertiary center on the basis we're already saying that they can decompensate very quickly. So I think it's a conversation you're going to have at the secondary hospitals as to what you have from a point of view of facility for ICU, facility for ventilation, facility for comfort of your internal medicine, and also your anaesthetists, and therefore, and also how rapid the transportation system is as a tertiary centre. It's a really complex one. My feeling is, I think any signs at all, they should move from a secondary to a tertiary care centre. And that, again, is based just on what we know so far, and having worked in a secondary centre a long way away from a tertiary centre, so I know the logistics of trying to move a patient when they're really sick.
To follow up on that, Colin, I guess from an ICU point of view, I would say take out the part of your decision making about the fact that she's pregnant. So the chance that she will actually decompensate to the point of needing to be intubated doesn't change the fact that you have a patient who may have a bit more of a difficult airway. Is there someone who is good at intubating locally? Is there someone who can deal with a ventilator locally? Can the patient be intubated and then transferred afterwards? So it really, I don't think we should change our management too much, just the fact that she's has that specific combination of COVID and pregnancy. So if it's a patient who is presenting with influenza and the patient is not pregnant, what would you do in that local center with that patient with severe influenza? Would you tube them or not tube them? So we do try to adjust for some of those factors, but I think we should still keep our basic hypoxemia algorithms in mind.
That being said, I mean, I think we have to also consider the gestational age, and I know this probably comes up as a question, is coming up as a question. I mean, if this patient is 21 weeks, I mean, I think that definitely makes sense. But if you've got someone in, what could be a viable gestational age over 23 weeks, there is a big difference on how a baby would do if born in a rural site versus in an urban tertiary site with full NICU support. So definitely, I think, our sort of thought is when you have a viable gestational age, is that very much, and if you have concerns about potential intubation, that mom needs to be transferred to a tertiary site.
Yeah, I think that plays into this presentation. It has to be a multidisciplinary decision. Recognizing what comfort you have at that facility as well, plus the gestational age, and when you're making that decision, again, it's how far you have to travel and what the time will be to travel to that tertiary site, which is, it's easy for us in the tertiary centre, so that we can smile because it's half an hour across the town in an ambulance maybe, but when you're 3 hours away, that is a huge consideration that has to be taken.
The other consideration too is transporting hypoxic patients when they have to be life flighted out, and they're going to be relatively more hypoxic on transport. So I would concur that those decisions have to be made a little bit quicker depending on how isolated you are and what type of transport you'd have to take.
Next question is, do we suggest unfractionated heparin versus low molecular weight heparins in critically ill pregnant patients because of the possible risk of delivery? Maybe Dr. Skeeth can comment on that, or
yes,
Dr. Blatchford.
Yeah, I think both can have our opinions. I think this is partly local culture, so there may be some differing opinions and practices. It's my practice, and for example, if a patient was admitted with COVID and they were pregnant or non-pregnant, then I would recommend a once daily low molecular weight heparin. I think this is a safer medication and know that it is good dosing. I do wonder about some of the underdosing with unfractionated heparin and having to give it multiple times a day for a COVID patient may affect exposure risk. So I think I would favor low molecular weight heparin, knowing that a prophylactic dose would wear out of the system in that kind of 12-hour window, but it really does depend on how likelihood that patient is going to deliver, talking with a multidisciplinary team. And I don't know if Dr. Blatchford has any other comments.
No, I would echo those. I think from a and I'm sure Dr. Thompson might have a comment based on the epidural and spinal, but then most recent ASRA guidelines would suggest the same duration of time from a obstetric dose of unfractionated heparin, which would be 10,000 units twice daily, as opposed to the standard 5,000 units twice daily in terms of a weight adjusted in volume and weight adjusted, as well as a dose adjusted for the difference in volume of distribution. And so with the change in the ASRA guidelines recommending the same duration of 12 hours from low molecular weight heparin, as well as from that higher dose unfractionated heparin, and trying to minimize nursing exposure in terms of injections, I would recommend low molecular weight heparin as opposed, but I wouldn't also recommend diverging from whatever your local practice is, instead of throwing a different wrench in the system.
Great, thank you. The next question is, how often are we testing women for COVID who present with HELP syndrome, but with relatively few risk factors for HELP, who don't screen positive?
I can take this one. I think part of this depends on the prevalence that you have in the community. So, you know, if you were in New York City, your threshold of testing someone because you're concerned with an atypical presentation would be a lot lower compared to if you're I'm trying to think of an area that doesn't have much, in Fort McMurray maybe. I think we're learning more about atypical presentations of COVID, and you know, they're right now, because there is so little published, and I think, you know, our current guidelines, we really do, we're focusing on fever, upper respiratory tract infections, GI symptoms, and potential exposure, not to say that not all of the above, but certainly, again, I think this might change on a weekly basis, so stay tuned.
Okay. The next question is obstetrical, and
Michael, I think Leslie wanted to pop in there for a second, and I just wanted to add something as well too. And if depending on the size of the center that you're in and the number of staff you have working there, I think you have to err on the side of caution when using PPE, because if people start getting exposed, you're going to run out of staff very quickly, depending on what the rates are in your local community. So it could put your hospital at a critical lack of staff, and not be able to provide service if a whole bunch of people get exposed to relatively asymptomatic patients. So I think that's something to be taken into consideration, is what your full staff potential is and how quickly you may run out of those people.
And just to comment on the HELP, the two cases that had coagulopathy and elevated liver enzymes that really mimicked HELP, both had normal blood pressures and no proteinuria. So I think if it does look more like a classic HELP picture, and somebody is otherwise well, I think that does not necessarily need to be fully tested, but maybe just to think about that.
And I think, you know, there's some argument, and there's lots of discussion about, should we be testing all women who are admitted for obstetrical indications like New York did? And I'm not a part of those decisions or those discussions necessarily, but, you know, that as the testing gets more accessible and faster, that might be an option.
excellent. The next is Stephanie, probably another great MFM question, and also for Dr. Au, Dr. Ng. In the extremely premature group, would the need for ECMO warrant delivery first?
I would actually let Selena answer that, I guess, you know, or even Nick, because I know that you both discussed this earlier.
I don't feel as qualified to answer it, but I'm certainly happy to give my 2 cents. But I think it would be an either or. I think if you're planning to go to ECMO, you would just do ECMO. But if delivery was felt to be most appropriate, then wouldn't plan to do 2 things at the same time. But I'll let Dr. Au give her expertise.
So when we look at the prematurity, I think if we're talking about first trimester, out of the case series that we looked at, there wasn't that many first trimester women. I think there was only one out of that group of 45, and the fetus did pass away. Out of the second trimester cases, the survival rate was about the mortality rate was 45%. And then out of the third trimester group, 20%. So that gave us the cumulative survival of 70%. So I think I would try to make the decisions separately. We can ECMO a woman who is pregnant. I think what we would do locally is that we would use a modified heparinization protocol. Full doses have been reported, but at the same time, there's been reports of significant hemorrhage. So women who don't survive on ECMO, they die because of multi-organ failure or hemorrhage. And the hemorrhage could be intracranial, it could be placental. There could be fetal intracranial hemorrhage as well. And so I think the modified dose would be the way to go, and I would consult our local ECMO experts for that. But I think if the age was so young that the baby would not survive, in order for us to put the woman on ECMO, I certainly wouldn't push for delivery. We would just ECMO the baby inside mom.
And I think, certainly, again, it depends on the definition of prematurity. I think, where we're really going to have some challenging questions if we're in that sort of 23, 24 week window where we have a viable fetus, but for which the morbidity and mortality of the baby with delivery is so high. So again, and I know that we've got some Toronto people on the line too, so feel free to put comments as well and ideas. So you don't have to just ask questions, you can give your experience or expertise as well.
Excellent. So Stephanie, Miriam Eng asked if you talked about the magnesium sulfate bolus for neuroprotection. Do you want to take this opportunity to talk about gestational hypertension and when we require an ongoing infusion, and what that, what the role of magnesium sulfate is in a COVID positive critically ill patient?
I think it's what we talked about, a balance. And so if you have someone with severe preeclampsia and very high blood pressures, then those are somebody who you really would benefit, we believe, from magnesium sulfate versus sort of milder gestational hypertension. At the same time, if you've got somebody who has severe respiratory symptoms and is critically ill, and if our internal medicine critical care colleagues feel that magnesium may be a detriment, then we have to, find a balance somehow. So, if we do have somebody who has mild symptoms, I don't think there's nothing that I have seen, and recognizing, again, this is all very new, to suggest we shouldn't give magnesium sulfate, but certainly giving the lower dose protocol, the 1 milligram versus 2 per hour, and also to just be very closely monitoring maternal symptoms and respiratory symptoms, and as well, of course, renal function as well.
Excellent. I'm just going to take this opportunity to address. John Kingdom has written in about their experience with HELP syndrome. So back from the previous question, he suggested that their one query HELP syndrome had normal placental growth factor blood test to quickly rule out HELP, and without placental growth factor, the gestational age times 10 rule for uric acid applies well. So thank you for that. The next question that I wanted to address was whether or not we felt that in COVID patients who weren't necessarily critically ill, but if we really think that there might be an increased risk for thromboembolism, do we think that there's a role for postpartum anticoagulation in COVID positive pregnant patients?
I can take that one. So it does seem to be quite a spectrum. From our non-pregnant patients who are in the ICU, our risks are high. On the ward, it seems to be similar to other medically ill patients, and I would extrapolate that. So if you had an outpatient who had COVID, I don't know if they would necessarily need low mercury heparin prophylaxis. I think the decision to use extended postpartum prophylaxis should be also look at other risk factors. So if this is a patient who has multiple other minor risk factors or more, then I would consider, but I don't think every patient, as long as things have recovered, things are going well. I don't know if everyone would need extended prophylaxis. Outside of pregnancy, we are not recommending discharging patients home on extended prophylaxis.
Excellent.
I'd echo, I think as long as a pregnant woman is admitted and has COVID, I think VT prophylaxis is absolutely indicated. And then in terms of the, again, just like Dr. Skeeth had said, an individualized approach, and you could use the, I guess in the absence of other information, you could use COVID as a kind of a medical condition within the SOGC algorithm and then apply the other frameworks. But I would agree at this point, it does not seem that COVID in and of itself is an indication for prophylaxis.
The next question relates specifically to breastfeeding, and if anybody has comments on experience with breastfeeding in mechanically ventilated patients or with breastfeeding in less severe postpartum COVID positive patients who are still admitted to hospital.
I can take that one. I get, yes, women can breastfeed if they have COVID. We're recommending that they have meticulous hand hygiene. So, assume your hands are dirty before you touch the baby, trying to avoid the baby's touching the baby's face, which of course can be challenging because, with breastfeeding, and breast hygiene as well. There's no evidence at this point that it can be transmitted via breast milk. If a patient is in the ICU, what we've done for patients we've had in the ICU who were wanting to initiate breastfeeding, or we certainly have used mechanical pumps for lactation, and we've done that with, not for COVID, but for other indications such as our postpartum hemorrhages. At the other thing, of course, so if that's the case, then making sure that the NICU and whatnot knows, and that we're being very careful about trying to reduce any potential contamination of the breast milk.
Excellent. Great answer. So there's another question about secondary centers with ICUs should be able to manage a lot of these patients. In this specific scenario, would transfer be related only to gestational age?
When we came up with our patient flow diagram, we decided as a kind of a zone within that the Calgary zone, that all patients between 23 and 31 weeks in consultation with our neonatology colleagues would be transferred only for the gestational age purpose. I agree with you that secondary centers from an ICU perspective can absolutely accommodate these patients, but within the Calgary zone, our neonatology colleagues preferred that from a NICU perspective, they be transferred to a tertiary level center.
Okay, excellent. Perhaps this is the next question is for Dr. Blanchard, and that's in the absence of obstetrical issues and if pre-viable, so less than 23 weeks, should pregnant COVID-19 be admitted to internal medicine with consultation or admitted to either labor and delivery or an antepartum ward?
I think it would, for me, it would go back to the reason for admission. If they not pregnant women with COVID in the absence of an indication for admission from a medical perspective don't need to be admitted at all. Like, we don't need to admit pregnant women with COVID for monitoring. And so if the reason for admission is medical and COVID-19, it's secondary to COVID-19, then I think it will, in our center, we decided that a medicine admission is warranted. I think, and you could advocate for that in your center because she has a medical problem and just happens to be pregnant. And then obviously careful follow-up from obstetrics that's gestational age appropriate.
If a patient is being admitted for obstetrical indications, for example, if you have a bleeding previa, and she just happens to have COVID, then that patient is better served on a antepartum ward. But again, I think we have to, recognize that people can deteriorate quickly, especially pregnant women. and really making sure that we're monitoring their vital signs and their symptoms very closely. And so we've decided that we're going to increase the frequency of vitals of our both our antepartum as well as our patients in labor, and really including oxygen saturations, which may not have been routine for frequent vitals, and instructing our nurses that not everybody has a respiratory rate of 18, because that seems to be on 95% of the respiratory rates pre-COVID for our pregnant women. So just recognizing that, and of course back to that close collaboration. So we will, talk to our medical colleagues and say, we've got a pregnant woman who does have COVID. She's on the ward right now. Her symptoms are X, but obviously if she gets worse, we're going to need your involvement. And potentially if we get a patient who has both terrible COVID symptoms and a terrible obstetrical situation, then we're really going to have to talk. And again, we look forward to hearing more centers publish about their experiences so that we can share from these experiences to help our own staff and our own patients.
Excellent. The last question that we have is actually, amongst pregnant women with COVID that progress to severe disease, are there any comorbidities that were recognized as risk factors for progression? And I'm going to ask Nick Papilia to comment on this. I think he's been looking into it.
Yeah, so reviewing the literature on these cases really seems to be a theme of one, cardiovascular disease or pre-existing blood hypertension, obesity, and type 2 diabetes was one of the initial comorbidities noted in the New England, the group out of New York that had the 43 pregnant patients. The two asymptomatics that became severely ill while admitted both had insulin-dependent diabetes. I believe in the one out of Iran that was ARDS also had an underlying valvular disease. So overall, I would say obese, hypertensive, or known cardiovascular disease, and diabetic would be the ones that I'd be most concerned with. I'd be curious though, the perspective of Josh or Selena from the ICU, if these are the ones that you guys are seeing as well, or if these are particularly unique to pregnancy.
To be honest, in the ICU in Calgary, we haven't yet encountered the pregnant COVID. So it would be really more relying on the literature on this one. But it does seem that age and comorbidities does impart predilection to severe disease.
It's really tough to look at the literature because often they will say, a comorbidity, and then when you actually look into it further, it's hypothyroidism. So, and a lot of the studies don't actually comment on comorbidities. And, one thing I do find a little bit frustrating though is that, people want it to be that the women have a comorbidity, but there are actually a number of critically ill women reported, or also again, back to some of the, even just the news publications, these are not women with comorbidities such as the respiratory tech from Washington or the nurse who died in the UK. So yes, we expect that women with comorbidities are at higher risk, but absence of comorbidities does not imply that they will not have the potential to become a very ill woman.
So interestingly, this is not the comorbidities driving the pregnant women, but there does seem to be a male predominance in the patients who end up doing a bit more poorly. So of the ICU admitted patients, we're seeing 70 to 80% male as opposed to women. And so I see that there's also this preponderance for some of our sicker patients to have STEMIs and the thrombosis components. I don't know if it's the male risk factor for heart disease, et cetera, to begin with, but I don't see as much critically ill women, if that's any, I guess, consolation in this.
Michael, are you talking?
Yep, I'm here.
Oh, sorry, we lost you there.
I know. The last thing that I was going to say, we just got a comment from Dr. Barrett in Toronto talking about their protocols for who wears an N95 at a COVID cesarean section. It was interesting. He noted that if there is conversion to general anesthetic, they leave in teams. And he suggested that there's some new guidelines coming out on that Monday, it looks like. So thank you very much for your comments. Does anybody want to comment on ECHO? Is that you, Stephanie?
Well, just because I know I've seen the Toronto protocols, and they recommend routine, I don't know if it's routine, but for use of echocardiogram, and more of a cardiovascular assessment. So I'm just would just like to hear the panels or even the audience's thoughts on what their centers are doing.
From a thrombosis perspective, if a patient is too unstable to get a CT scan, if you're worried about decompensation in PE, then a lot of centers are using echocardiograms to better assess findings for PE and treating empirically. I can't comment on the cardiomyopathy piece postpartum, but also something to consider, I think.
I don't think echo has been a routine part of our critical care in Calgary, but when it has been done, there is some evidence of right heart strain, perhaps as a result of hypoxic pulmonary vasoconstriction. We've had a variety of fairly catastrophic cardiac outcomes in the ICU with 3 STEMIs in COVID positive patients. So there's certainly a risk for major cardiac complications with this. So if somebody is doing poorly, we obviously would do an echo as part of our assessment.
I think from my perspective, if the patient's symptoms don't match just COVID, then there's value in thinking about other things like VTE or other cardiac involvement. I think the challenge with echo is that you're exposing the echo tech and the machine, which is not an insignificant exposure, especially for the echo tech for a complete echocardiogram. If your question is just about biventricular function, then that's something that can be done more on a point of care. I think a BNP would, for me, be a better screening test to start. And if the BNP is normal, then the likelihood of having a clinically significant cardiac contribution to hypoxia is much less. And so while it wouldn't preclude the use of an echo, I think it, particularly in this circumstance, might minimize the exposures to both the tech and the machine, as well as make your patient selection a little bit more narrow.
There's a comment here also again from Dr. Kingdom about using BNP for both picking up subclinical heart failure in early onset preeclampsia, which is what they're doing at Sinai in Toronto. That's excellent. Thanks for that comment, Dr. Kingdom.
If we ever do this webinar again, Dr. Kingdom is now officially invited to the panel.
Sure. I think that might be all of our questions for now. If there's any other last minute questions, please, we welcome them right now, but I think we'll probably sign off and call it an evening for now. We really appreciate everybody who attended and thank all of our panelists. You guys brought amazing expertise and amazing opinions to this. So look forward to disseminating this online in the next few days. And we will be in touch shortly. Thank you, everybody.